We're just about to start. And pronounce your last name one more time.
Paolone.
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 Yeah. Okay.
Paolone. Ready? In 3, 2,
I'll roll on this one.
1.
All right, well, we are back live once again from the American Academy of Fixed Prosthodontics meeting. It has been a great day. It has been action-packed, Wes. We have had some high-level...
My brain is exploding
yes,
right now.
My brain is getting full, but it is not quite full yet.
Right.
Because we have another very distinguished author with us today, Dr. Paolone from Italy, who has, of course, Quintessence has been a part of bringing us here today, and they actually showed us this book because it is just coming to our world in English.
Yep. To be released soon, from what I understand.
And it is entitled Posterior Direct Restorations.
Yeah.
Thank you for being with us today.
Thank you for the invitation.
Yeah, we're excited to talk to you because this is, of all of the topics we have had today, this is the most applicable to the everyday.
Yes.
Every dentist, every restorative dentist needs to know what is in this book.
Yes, it can be also used by different level, different skill. If you are a student, or even if you are more skilled, there are some tips and tricks you can gain from this book.
Yes, yes, and that's exactly what I'm seeing from it. And I want to dive right into some of the topics that everybody will be wanting to know the answer to. One is, let's talk about matrix bands and class 2 composites.
We're going there because this is Geek Fest on our show.
We love it.
And I think the thing that makes this great about this book, and as I looked at the table of contents and kind of perused through it there just before we met up, I thought, John, this is the situation where we have, we talk about composite dentistry and how hard it is.
Yeah.
And I think there's so many clinicians that, I don't want to say embarrassed, but it's hard to ask about the simplest things we do in dentistry.
Yeah.
And it took a long time for John and I to feel like even comfortable even talking about composites. And, John, you're jumping right into, like, one of the top things, right?
People want sometimes in dentistry to look at what is the newest thing.
Or the things that they will never do, maybe.
Yes, we'll never do, but this is every day. These are the things that can make your day either smooth and easy, and patients are happy and they're not coming back with sensitivity.
Yeah.
So let's talk about the matrix. How do you choose a matrix system for class 2 composites?
Yes, this is important what you said, that patient doesn't complain. For example, in class 2, the major complaint is the loss of a contact point. So it's important to choose and to select the proper matrix system. So there are basically 2 types of matrix system, the circumferential ones, so the flat ones, and also we have the sectional matrix. Well, it's better to use the sectional matrix because they are convex. They mold exactly the shape of the interproximal area. And the problem with the circumferential one is that they bring the contact point up where there are the occlusal embrasures. So maybe you get a contact point, but you have to remove when you check the occlusion.
Yes.
Instead, with the sectional matrix, you get the contact point exactly where it should be.
And it's broad, and you don't have a big open embrasure space for food trapping. And those matrix systems have come a long way in the last 10 years, right?
Yeah.
There's been a lot of development.
Absolutely.
Lots of new systems out there.
Systems with treatment of the surface, the inner surface, different types of separators, of clamps.
Yeah.
And yes, there's still some development, but all the developments is based on the basics of the concept, so the sectional matrix. But of course, improvements are how to avoid overhangs, how to optimize the contour of the filling. So the improvements are to let the clinician have less to do adjustments afterwards.
Yes, and I want you to speak a little bit to that because a lot of what we were seeing in the book was about how to not have to spend a lot of time taking away all of this composite that you just spent all the time putting in. So what are some of the concepts that you teach somebody to avoid the excessive adjustment?
The problem is that the first part of the book is focused on the concept of the anatomy of the form. So if you know how the teeth are made and you know how to read the residual anatomy of the perimeter, then you can apply your material and reduce a lot the occlusal adjustment. You just have to, of course, have the knowledge of the anatomy, but you have to project the remaining tissue towards the center of the modeling that you're going to do.
So you would rather teach maybe a student that was learning this how to read the anatomy of the tooth rather than and carve that in.
Yes, because you know the problem that generally during some courses or classes, you learn how to do always the same tooth. Instead, the concept that we wanted to outline is try to understand the substrate that you have, read the stiffness of the cusps, and then, of course, link it with anatomical knowledge in order to give the modeling the best option and reduce the occlusal adjustments.
Now you talk about the matrix system, but there are also, when you're placing composite, there's a lot we could unpack here because the Class 2 composite is so many things. But let's talk about tooling. Let's talk about the instrumentation. What types of tools, what types of instruments are you typically recommending?
I teach to the university, so I have to teach the simple stuff. So simple burrs in order to obtain the cavity shape of the box. But of course, there are several steps you can improve in your clinical practice. You can use reciprocating instruments. You can use ultrasonic tips in order to shape perfectly. But of course, in this book are described all the ways to obtain the same goal. They are not linked to a specific system because we wanted just to explain the concept and leave the clinician free to use what they have. For example, consultants, maybe they have limited tools, but with the simple tools we can obtain all the...
When you place the composite into this preparation, of course there's steps before that are so important with bonding, choosing the proper bonding material, and also the technique. So let's talk a little bit about, obviously we can get into generations of bonding materials, and I think that would be great, even though we're not going to necessarily mention products.
Absolutely.
What type of generation of bonding material are you recommending, and how are you talking about, say, things like total etch versus selective etch and things like that?
I almost stopped to use a total etch in posteriors because all the issues related to post-op sensitivity, which is the pain you have after you do a class 1, for example, on a child, that when we used amalgam it was very easy, but when we use composite sometimes we can have. I stopped to use total etch systems because they provide sometimes post-op sensitivity, and I prefer to use a self-etch approach. So if we talk about generation is fifth, it's 6, 7, and I prefer to use a selective etch, so I just etch
enamel margin
in order to have a better seal, bond strength, but not going to etch with the phosphoric acid the dent.
Do you think C factor, this is geek stuff right here, do you think C factor is even an issue today?
Well, nowadays we have smart materials. We have materials like, for example, the bulk fill, which are material very interesting from how the composition point of view. You know, companies sell bulk materials because they can elude the clinician, they can fill quickly, but they are nice because they have some nice technology that avoid the stresses during the shrinkage. So people think that bulk fill materials, they do not shrink, they shrink.
Yes.
But bulk material, while they shrink, they lose the tension inside, so that it's quite good. C factor is quite important because one of the reasons, for example, for post-op sensitivity is because the strength of the shrinkage can detach, for example, the adhesive system from the wall. And the nightmare about post-op sensitivity is that I think there are about 10 reasons. If we try to match the dentin, for example, if we use a total etch, if you leave too much wet, if we heat too much with the curing light, there are so many reasons, and so this is quite very skill sensitive. And I think that when we use a self-etch system and also a low shrinkage stress material, we can reduce a lot.
What is the role of flowable composite in your view with Class 2?
It's great. I was going to ask the same question.
Flowable, there are tons of articles that say, for example, in Class 2 margin that you can place it or you cannot place it. Nothing will really change anything of the outcome. I use the flowable because if it's true that micro leakage is not the reason for secondary caries, it's true that macro leakage is the reason for secondary caries. So I prefer to see that everything is covered and then apply a paste composite.
Okay.
But it's not mandatory. Some people think that if you put it for elastic reasons.
Right.
I just use it because they are.
Are you doing bulldozer technique where you
snow plow?
Yeah. You know, where you would put a little bit of flowable around the margin area
and not cure it.
Not cure it yet, but then
yeah, I know this technique, but I don't use it because I want to have some articles that support it.
Okay.
I'm still waiting for some clinical, maybe a clinical trial article that say, okay, we have seen 10 patients treated in this way, 10 patients not treated in this way. It's safe to use it. So,
but essentially, what you're doing is you're taking that and flowing it into and around the margin to provide not microsil, macrosil, right?
Yeah.
And that, in a sense, is not for flexing. It's not for occlusion.
It's adaptation.
It's adaptation only. Adaptation only.
You know, I tried once. I have to be clear. I have tried once. Maybe I put too much flowable. I found the flowable everywhere.
Yeah.
Mm-hmm.
So it's difficult to manage the quantity of this kind of flowable, and you find it occlusal, and so you have to remove it. And it's a pain really to remove it while it's flowable and also when it's cured. So
you mentioned with the same idea here of matrix systems and adaptation with flowable. You know, in your book, you talk a lot about isolation.
Yeah.
And I don't know that there's anything more important really in the end with these, because I mean, in your opinion, is the number one cause of post-operative sensitivity? Do you think is there a number one cause? Is isolation a big problem?
Saying that if you don't apply rubber dam, you will get post-op sensitivity, I think it's not fair to say. It's not true. But of course, what we know is that the materials are, they fear a lot humidity and contamination.
Mm-hmm.
And in my hands, the better way to avoid this is to use rubber dam. Of course, there are some skilled clinicians that can obtain a very nice isolation through the use of cotton rolls, Teflon, all the techniques. Mm-hmm. But I think, and I teach it because I believe it's a very good way to isolate. And you know, everything is changing in dentistry. If you go to the exposition, you see new scanners, everything new, but isolation is the same from 160 years, something like that.
Is there any new rubber dam material on the market?
Yeah.
You know, right?
Right.
I mean,
it's not sexy.
It's not sexy.
It's not sexy, yeah. But you know, that's why I'm quite excited, because we have obtained from the Iowa University the permission to publish a very old picture in the chapter of isolation, where is over there. Let me see. And is this? Can I show you?
Yeah.
Sure.
Hold it right up to the camera.
It's from the latest years of the 19th century. So it's
and look what they've got in their mouth.
They've got rubber dams.
They have rubber dam from the Iowa University. It's incredible.
So people have felt the pain of having to learn to use a rubber dam for many years.
Yes.
But it's worth it because we're seeing predictable isolation.
Well, especially in a busier practice, John, where you're maybe checking hygiene, you're doing some other things, and you've got to get up from the procedure. Yeah. We know that it's paramount to be able to get up, walk away, and then come back and still have the same isolation. You know?
That's what I teach to my students, and I also invented a template which is called PACDAM, because it seems a Pac-Man, but PACDAM, and has the three concepts of isolation, the three scenarios. So the anterior part, the single tooth, and the sector, that I think they are the three common scenarios of isolation. So,
and this is a product it's a template that shows you how to punch your holes more quickly, and it has all three scenarios.
All three scenarios
inside.
Built into, and it's called
PACDAM.
PACDAM.
Okay.
Because it looks like Pac-Man.
.org if you are interested.
Okay.
PACDAM.org.
Cool.
.org.
So
very cool.
You mentioned in the book a concept called detailing. Talk about what is detailing. What does that mean?
Detailing is making your restoration more nice, more detailed, not common. You know, everybody.
Because let me just stop you for a second. Because in Italy,
not common.
We make things nice, right?
Yes,
I mean,
I didn't want to. I didn't want to.
No,
say
no,
that.
no. You should say it. I mean, and there's nothing wrong with it because we have seen
Italian clinicians are amazing.
Style Italiano, for instance.
Yeah.
You know, we have seen.
We are close friends.
Yeah,
Marcus Vargas.
Yeah,
Marcus Vargas.
Marcus Vargas.
Yes.
Yeah.
Close friend.
Yes.
Yeah, and
Close
we have
friend.
seen.
Love him.
Yes, and we've seen people like Marcos, and we understand that there is something special going on in Italy with regard to making things beautiful.
Yeah.
And it sounds like
This chapter is about this.
Yeah, and that's good.
Yes, it's how to make more nice, more interesting, not schematic, not artificial, your restoration.
Yeah, yeah.
Rather than just some flat carves.
Yes,
you thing.
Push and across.
Right.
It's okay.
How does that make? How does that make your dentistry better?
Yeah.
This approach.
Yeah.
Well, I think that when you do something, the best thing you can do, and trying to do it at best that you can.
I love it.
Right.
Yeah.
I
Take it to the next level, man.
There is a value to that in terms of how you feel, what you would want to do. You know, as people sometimes say, for your wife, for your girlfriend, for your best
absolutely.
friend. If that's how you can do your dentistry, there's a pride to that. That we
For
should
example,
want
staining of the grooves. Nobody likes the staining, but if you want, because it masters your restoration, if you like it, why not? Because you are trying to reach an high level.
Let me ask you a question. What do you think that microhybrids still have a place in dentistry?
Well, microhybrid changed dentistry, restorative dentistry, because we moved from microfield to microhybrid, and finally we had more structure. I think that now we have nanohybrids, also we have nanocluster, and yes, they can have, but I think that we can take advantage of nanohybrid nowadays.
Yeah, even microfill is becoming
more popular again,
yes,
because you can polish very
but even some of these new nanos, our polishability is amazing.
Right, we talk about some of the things what we're doing now, where we're doing transitional bonding, and basically very little preparation, and you have such a fine edge, right? An infinite edge. There's really no bevel.
Yes, you know the problem with microhybrids, they needed a thickness.
Yes.
Otherwise, they will chip.
That's what we're finding, is that there's some.
Now the nano clusters or the nanohybrid can behave better in a thin layers.
Yes, and there's something. I know last year we were here, and I think it was Daniel Galindo was talking about spherical particles and some of these composites, and how well you can create almost an infinity edge without any structure, you cannot detect. And that's we just couldn't do that years ago. So this topic that Wes just mentioned of transitional bonding, thinking about composite as obviously as a definitive restoration, but also sometimes as an interim restoration that we're using to bridge. What do you think we are in terms of things like wear characteristics, using composite as a long-term provisional or maybe as a definitive? Where do you think this fits?
Well, materials nowadays are more and more performant from a mechanical point of view. So I think that with the nanohybrids ones, we can allow ourselves to make a treatment in a very precise way. And I would not say just long-term provisional, because sometimes you can make a long-term treatment, of course, with, let's say, a definitive material like ceramic, zirconia, but sometimes you do not want to have a high modulus of elasticity.
Exactly.
Because of the wear issues of the patient. So sometimes I'm referring, for example, to the articles from Francesca Vailati and all the three-step stuff. Sometimes you want something that can adapt a little, so that you can check and maybe refresh and update and mold again.
That repairability as well.
The beauty of repairability is amazing.
And I think that's something that we're finding more and more. The more we're taking courses on full arch, I think for years, and obviously at a meeting like this, you're going to see a lot of full arch lithium disilicate, and that's wonderful.
Which is a wonderful material.
And it's a wonderful material,
Absolutely.
but not every patient can come in and pay for 28 lithium disilicate crowns right now, but they could maybe do that over 5 years or something,
and repair and do it once again in a cheap way.
Yes, and I think that's where we're seeing more now in some of the courses that we're taking. That is, how do we segment these cases? How do we make these cases more affordable? And what's happening, I think, with these newer materials in composite is sometimes the composite is good enough that we don't need to look at it as transitional. We can look at it as definitive.
And we mimic much better than sometimes some ceramic.
Where are we at with indirect composites? I mean, that's something that I toyed with early on in my career, you know, with some of my patients whenever you felt like isolation's tough here to do a direct restoration, and there were products available, oven-cured composites back in the day. I mean, those type things. Where are we at with indirect composites today?
Well, I do it very often in indirect composites. I feel it that is nice, easy to do. They blend sometimes even better than lithium disilicate indirect restoration. Of course, the surface is not stable as ceramic, of course, but has some indication. It's a more affordable material, but it's not the main reason to use it. It blends, you can repair it, you can fix it, you can change it. It's very conservative. I love the approach. And we have nowadays this material, if they are cooked, they are converted, they are polymerized in the laboratory, they behave very well. Especially, for example, for single partial adhesive indirect restoration, they behave really very well.
Now, when I see a book titled Posterior Direct Restorations, it begs a question in my mind about anterior direct restorations.
Well, the good news is that it's ready. It will be published in May in Italian, and then
Anterior will be published in May. So that's coming.
In Italian. When's it coming to English?
I don't know. You have to ask Quintessence.
We'll have to ask Quintessence.
Bill, please.
Yeah, that's right. We'll talk to them about that. But that's so interesting. So you are building on this idea of being able to have posterior and anterior direct, and a lot of the same folks that we're talking about probably that are doing this at a high level, because, you know, anterior direct restorations is that's an art for sure. And that's something that
also in that book we would like we wanted to explain techniques easily so that everyone can apply a procedure, because sometimes we treat it as an art, and of course you have to have some manual skills, but we wanted to transfer to the people, to the clinician, the step-by-step procedure to obtain even a basic result, but acceptable result.
That's what we need. Yes, because I've been to so many courses where, you know, they will show you what's possible, but it is very much a little of this, a little of that.
But they only can do it.
Right.
This
and we need systems. And that's what you're trying to develop. I love that.
I love it. Okay. And I think one of the things I'd like to ask is give us a tip of the week. Right? We dabble in that a little bit by offering up little clinical tips. But give us a tip of the week, maybe
something we can change.
Something we could change, or maybe something you say, you know what, I just can't live without doing this thing, or
maybe it's a burr, maybe it's a specific type of tool, or is there something like that for you that is just your go-to?
Maybe just say, like, this is the way I do it, and you really need to try it this way, something like that.
Something I really find useful, which is quite controversial when I lecture about it or when I do classes or courses, is then when I do the centripetal build-up, so when I convert from class 2 to class 1, I generally stop everything and finish the wall that is built. So this is controversial because they say, this is a contamination, you have to powder anything. I think that if you do it, then you inflate air and remove all the dust, and then you apply some bonding again. The benefit of it is that you have a perfect boundary, you have a perfect definition of the external anatomy, so that you have all the information just to make an interpolation towards the center. And so you will avoid a lot of occlusal adjustments.
So you're doing your class, your box.
The box, and
restoring the wall.
And we modify the box.
Yes.
Interesting. And then you will, but I would think, going back to avoiding a lot of adjustments, that would allow you to do that, because you're seeing the anatomy the whole way through.
Well, by that way, you're able to take your sectional matrix off and look at the adjacent marginal ridge.
Perfect. You just have to leave the wedge, of course.
Leave the wedge.
For the bleeding.
No bleeding.
Even if you have rubber dam, there's some bleeding.
Exactly right. Exactly right.
Well, that's a good little trick.
That's a good tip.
That's a good little trick.
Tip.
Well, so tell me, you mentioned earlier that you have not only the book, but also that you have some online education.
Yes, we have our website, which is called werestore.it. It's in English. And then we have our channel. It's called adhesive-dentistry.com. You have online lessons. There's a channel you can subscribe, and of course there are some lessons specific on how to bond in direct in zirconia, in composite, how to isolate, adhesive strategies, fracture reattachment. All these lessons are covered in our channel.
Excellent. Well, we'll check that out. I mean, this is, you know, to have the book available, but also to have online. That's what people, I think, are finding, is that having the book is kind of learning the technique, but then seeing it in action in a video allows for you to be able to really implement this into your practice. So that's a complete solution.
And I will say this. I don't know what it is about Quintessence, but they know how to pick people that can take wonderful pictures.
Yes.
The photography in
this book,
next
level.
It is next level. It is so good.
Thank you.
And so I really appreciate you coming on and talking to us about posterior direct restorations, man. It's bread and butter dentistry.
Yep. Done at a high level.
Done it at a high level.
And
John?
it's beautiful, right?
Thank you.
Because it's from Italy. So it's going to be beautiful. So, well, we've enjoyed, once again, getting to spend some time with you guys, and we hope that you've enjoyed this interview. If you've enjoyed this, if you're connecting with this, we want you to connect with us through our social media outlets on Instagram, YouTube, Facebook. Tell us what you liked. Tell us what you want to see more of. And make sure you subscribe on Apple Podcasts so that you can catch the next episode of Dental Guys. And so for Wes, for Dr. Paolone, and for myself, we are the Dental Guys.